Thank you all for joining. We'll be giving everyone a few more minutes to join us, and then we will start the webinar. Hi, everyone. Thanks again for joining. We will get started in the next few minutes. Great. Thank you all again for joining us for this webinar. This is the fourth webinar in the Gradient Critical Care webinar series, and where we'll be focusing on principles of oxygen therapy. Just before we get started, I just wanted to share a couple of housekeeping points with you and answer any questions that you might have. If you have any questions during the webinar, please use the Q&A function at the bottom of your screen to ask us. We will get to the Q&A portion by the end of the webinar. You're also welcome to raise your hand at the end of the webinar during the Q&A series to ask your question live, and we will unmute you. The webinar will be recorded. You'll receive a copy of the webinar following, you'll receive a copy of the recording following this webinar. It'll also be on Gradient Health Systems YouTube channel as well as our website at gradienthealth.org/howwework/training. And then if you have any feedback or any questions or have any suggestions for our upcoming webinars, please feel free to reach out to us directly at customers@gradienthealth.org. And we would love to hear from you on your feedback for this webinar as well as future webinars as well. I will now turn it over to our moderator, Dr. Ndaba, who will take us through the first few slides and introduce our presenters as well.
Thank you so much, Mariam, and welcome everyone. We thank you for finding time to join this discussion. My name is Dr. Ndaba Sipuka. I'm an anesthesiologist from Zambia. I'll be your moderator for this session. Our presenters for this afternoon session, we have Dr. Alex Luiza, who is an anesthesiologist and critical care specialist from Tanzania, who will take us through the first part of the session. And then the subsequent or second part will be taken up by Dr. John Kweyamba, who is also an anesthesiologist and a critical care specialist from Tanzania. So I welcome you all. Like Mariam has mentioned, feel free to post your questions or any comments in the chat box as the session is going on. We'll also try and share some of the links to the literature for you to read through at your own time. So without wasting much of your time, I would like to introduce our first speaker, Dr. Alex Luisa. Dr. Alex Luisa, kindly take it up.
Thank you, Dr. Ndaba and Mariam. So welcome all of you to this session of Principles of Oxygen Therapy. As introduced by Dr. Ndaba, my name is Dr. Alex. I'm an anesthesiologist at Kilimanjaro Christian Medical Center. So I'll be just taking you through the first part of this presentation webinar, which is the most interesting part, because without this, it will be very difficult to understand the coming part, which will be presented later. So the overview of this webinar, it will just be covering the oxygen therapy. Why do we need to know it? Because oxygen is very essential, especially for our patients who are severely and critically ill. And then also, why oxygen? Because the WHO has listed oxygen as an essential drug that must be available in all healthcare facilities at all times. And then another thing which we must know is that oxygen must be prescribed and administered according to patients' oxygen requirements using specific oxygen delivery devices. And then also the different sources of oxygen which exist in our settings and elsewhere. But the most important thing which we should know, and the reason why we are having this webinar today, because it's important that healthcare facilities and providers that we build capacity and invest in oxygen resources in order to enhance patients' care and improve outcomes of our patients. So can I have the next slide? So the objectives for this webinar today, mostly the part which I'll cover, it will be to understand the physiological importance of oxygen and also to describe the importance of oxygen therapy, but also we'll describe the clinical indication for oxygen therapy, but covering on hypoxia. And then my friend will take you through the different oxygen delivering devices for oxygen therapy, but also understanding different ways which you can use for oxygenation or improve the hypoxia. But also we'll discuss on the complications of inappropriate use of oxygen therapy, and also we'll describe the different sources of oxygen as I mentioned earlier. So this will be outlined for our day. I'll cover most of the oxidative phosphorylation and also complication of oxygen therapy, clinical goal of oxygen therapy, and types of hypoxia. And then my friend will take you through the rest. Can I have the next slide? So the most important thing, why do we need to learn, or why do we need to understand about oxygen therapy? The first question should come into mind is why oxygen, and why do we need oxygen for our patients? So normally, I'm sure all of us who are attending this webinar, we are breathing currently. None of us is on the ventilator. So we take in air, which has oxygen about 21%, and taking it to our lungs, whereby it through diffusion, it diffuses into the blood, and then transported to different tissues in our body. So why does it need to be transported to different tissues in our body? Because oxygen is the key important factors for energy production and energy utilization in your body. If you remember the ATP production from our mitochondria, if I can have the next slide. So I hope we all know about this oxidative phosphorylation, which is the most important part in our cells. This is a part of cellular respiration, where the mitochondria within our cells use enzymes to oxidize nutrients, thereby releasing chemical energy, which produce the 38 ATP, adenosine triphosphate. This can be through two ways. This is usually through two ways: the electron transport chain, where the oxygen is the key important factor. Without it, that's where you go to anaerobic respiration. But we know the way which body were designed, it was just for aerobic respiration. And then you have the chemiosmosis, whereby you end up producing the energy. So if I can go back to the previous slide. So what will happen when your body usually sense you don't have enough oxygen? So normally this condition, we call it hypoxia. We'll see later on the definition of terms, how to differentiate the terms. So if you lack air, or if you have air hunger, or you have oxygen hunger, your body can just detect it through different chemoreceptors in your body. So normally that's where your body will tend to increase the intake of air so that it can increase oxygenation into the blood. But this will depend in the nature of the oxygen or air hunger. It can be acute or chronic. But for the case of acute, when the oxygen delivery is compromised to the organs or tissue, the response will be mostly organ specific. So if you just we just go for the CNS, that's where you see your altered mentation, or your patient can become restless or end up to coma if you lack oxygen. But in order to increase more oxygen to be taken up into your lungs, you can use accessory muscle. You can have tachypnea or deep breath, depending on the state of the patient at that moment. Can I have the next two slides? The next one? Thank you. So as I said, we will define the terms which we use normally on oxygen therapy. So starting with anoxia, this is when there is no oxygen availability in the tissues, completely no oxygen. So it's anoxia. Hypoxia, which is the main focus of webinar for today. So this is lack of oxygen availability in the tissue. So you have oxygen, which is there, but it's not sufficient enough for ATP production or cellular respiration. And then there is hypoxemia. So this is lack of oxygen in the blood. And then there is FiO2, which we normally use it when giving our patients oxygen. So this is a fraction of oxygen in the inspired gas. So normally what we breathe at the moment, I assume almost all of us, we breathe the air, which has 21% oxygen. But if you are to supplement, you can supplement from 21 up to 100% of oxygen. And then you have partial pressure of oxygen. So this with a small a, or it can have a capital A, depending if it's arterial or if it's alveoli. But with a small a, that's arterial. So this is the measurement of oxygen pressure in the arterial blood. And then you have SpO2, as we normally or we regularly write it, or SaO2. So this is oxygen saturation. So this is a fraction of oxygen saturated hemoglobin in relation to total hemoglobin in the blood. So since it's a fraction, is explained up there on the FiO2, that it's usually written in terms of percentage. This is what you get from your pulse oximeter. The partial pressure of oxygen, that's what you get from your arterial blood gases. Next slide, please. So when you sense your patient has hypoxia and you need to supplement the oxygen, so normally that's what we call oxygen therapy. So from this webinar, we'll define the oxygen therapy as administration of oxygen at concentrations greater than that in the room air, which, as I said earlier, it is 21%. Normally, or usually, we just do it to treat or prevent hypoxia. But there can be other conditions, which my friend will explain later, which you can also supplement oxygen. So this can be delivered by different devices, and my friend will cover on that later on. So why do we need to know about oxygen, or why do we need to be very careful when giving oxygen? So as other drugs which we normally administer to our patients, so oxygen, it's also a drug. So when you're giving oxygen, you should be making sure that there are specific indications that your patient really requires oxygen. It's not for everyone. And then also the prescription of oxygen should include the target range for the oxygen saturation. What are you aiming for? if your patient saturates 100, is it okay? If a patient saturates above 92, is it okay? So you should set a target. What are you aiming for? But also the response to oxygen administration requires regular monitoring. You must start at 40 and then your patients improve in terms of the oxygen saturation. But later, depending on why was the patient hypoxic, the condition might worsen that you need to increase the FiO2, the fraction of inspired oxygen of your patient. So you need to monitor your patient. Sometimes not only upping the FiO2, but also you might need to lower the FiO2 as your patient improves clinically. So as we should know that oxygen is important for tissue oxygenation, but also has hemodynamic effects. But also we should consider the effects on inflammation, effects on microorganisms and tissue repair mechanism. This we see it on the next slide. If we can be taken to the next slide. The next slide, which has oxygen toxicity. So these are the possible complications which might happen when you give too much oxygen than the required that patient. So we have something called oxygen toxicity. So this is more to do with free radicals which can be released due to high amount of oxygen which is being delivered to your patient, which the patient does not really require. So this can be experienced from neonates up to adults, but different presentation can occur depending on the age of the patient, also depending on the exposure period or time of that high amount of oxygen. So in terms of different systems, as you can see on the image, which is on the right side of your screen, so you can have a respiratory system complications or CNS complications, which can end up to dizziness or headaches or disorientation completely, or even have visual complications, which can end up to visual field loss, and especially which is experienced by the prematures and neonates. But also you can have musculoskeletal with twitching, and also respiratory, you can have cough, pain, shortness of breath. Instead of your patient improving, you might find that your patient is worsening in terms of respiratory wise, only because you've given much amount of oxygen which was not even required. So can I be taken to the previous slide? So how does the oxygen, we talked about the FiO2, we talked about partial pressure of oxygen, which I said can be arterial or alveoli. And then also we talked about saturation. So how do they relate? So mostly the oxygen will diffuse, as I said earlier, from the lungs to our blood. So through the alveoli, depending on the partial pressure, that's how much oxygen also will diffuse into the blood. And then upon diffusion, the oxygen will be carried by the hemoglobin, whereby the hemoglobin are found in our red blood cells. So normally one hemoglobin molecule can take up to 4 oxygen molecules. So the diffusion will also depend on multiple factors. So as you can see on the graph, this is called the oxyhemoglobin dissociation curve, showing the relationship between the oxygen saturation and the partial pressure of oxygen in millimeters of mercury. So normally only marginal increases in oxygen content will occur with saturations above 80 to 90. So this, you expect that 80 or 88 up to 90% of your hemoglobin have been saturated with oxygen. So the uptake also will increase, will be marginal increase. So in severely hypoxemic patients, we normally, when we treat our patient, when we do the oxygen therapy now, we usually start with 100% oxygen, assuming that you have very high partial pressure, because also you want to get directly high saturations. But remembering what I just from talking, remember the short-term risk of oxygen if you have given too much oxygen, so the oxygen toxicity. But Relatively, the studies have found that short-term risk of low oxygen is greater than short-term risk of too much oxygen. So when you start, you can just start with 100%, but don't leave it. Continue monitoring your patient. If the patient improves, does not need the 100 again, you can start wean off the FiO2 so that you avoid the toxicity. Next slide, please. Next one. So before giving oxygen, what are the important questions which you should ask yourself? So as I said earlier, oxygen is a drug, so not recommended for everyone who comes to the hospital, rather than the people who are indicated to have oxygen therapy, but also should be the indication and the administration of oxygen should also be thought after thinking or considering about the underlying medical condition. But also you should consider what are the resources which are needed for you to provide that oxygen therapy. Do you have the right devices? Do you have the right oxygen tanks or the concentrators? Sometimes you might need the hyperbaric oxygen. And then also, what are the potential hazards of putting your patient on oxygen? Next slide, please. So most of the time, as I said earlier, we do oxygen therapy. We administer supplement of oxygen to our patients to prevent or treat hypoxia. As we saw earlier, when the patient sense hypoxia, they will tend to increase their breathing rate or the depth of breathing. So you get increased work of breathing, but also you strain your heart because it has to pump a lot of blood to increase the cardiac output so that it can increase the tissue supply of oxygen. So when you give oxygen therapy, what you expect is that your patient will improve in terms of reduction of work of breathing, but also you reduce the strain to the heart. Next slide, please. So what can be the causes of low blood oxygen? So maximum oxygen concentration in the alveolar space usually depends on barometric pressure, also the fraction of oxygen in the inspired air, and the concentration of carbon dioxide in the alveolar spaces. So atmospheric causes of hypoxia most of the time will be decreased fraction of inspired oxygen. You see the picture over here on the right side, which is the Uhuru Peak, Tanzania. This is our famous Mount Kilimanjaro, the highest point in Africa. So you will see later with the increase in altitude, you get a decrease in pressure. So I'll explain that later. So other causes can be due to cardiopulmonary causes. Most of the time is VQ mismatch, ventilation perfusion mismatch. When you have hypoventilation, poor ventilation, or you have poor perfusion. So when there is dead space or shunting of blood within the lungs, that's when it can also lead to tissue hypoxia. But also when the heart is not functioning properly, when you have decreased cardiac output, so the tissue perfusion, when it's impaired, you also expect that the oxygen will also be impaired. The oxygen delivery will also be impaired. Next slide, please. So what are the important equations which we should know to know that our patient have optimal oxygen carrying capacity or optimal oxygen delivery? So the most important thing which you should know is, as explained earlier, oxygen in our bodies is being carried by our blood. So this can be through two mechanisms. One, it can be dissolved in the plasma, or it can be bound to the hemoglobin, which is about 97 to 98%. So the equation, as you can see over here, 1.34 times HB, the HB, hemoglobin concentration, and then times the saturation of oxygen divided by 100. And then you plus 0.003 because very small amount dissolves in the blood, the partial pressure of oxygen in the arterial content. So there's missing A on that equation, on that upper equation over there. But the PaO2, that's the partial pressure of oxygen in the arterial blood. So how much is being delivered to your tissue? So the delivery of oxygen to the tissues mostly depend on the cardiac output. So how much can be carried from your blood, in your blood, and then how much is the cardiac output. That's how much is being delivered to the tissue. So from the above equation, which was the oxygen carrying capacity, then we just multiply it with the cardiac output. So the delivery will always depend with the how well is your heart functioning as a pump to circulate that oxygen throughout tissue, all the tissues. Next slide, please. So as I said earlier, in order for you to know how to provide good oxygen or appropriate oxygen therapy, we should also know when will you need oxygen therapy. As I said, that mostly of the time, the oxygen therapy will just be indicated when your patient has hypoxia. So it's important also to know what are the types of hypoxia and what should I anticipate if I give oxygen to this type of hypoxia, and if the patient is not improving while I have hypoxia and I've given oxygen, am I doing the right thing or I should look for another therapy? So to start with, you have hypoxic hypoxia. Next slide, please. So hypoxic hypoxia, as I said earlier, the oxygen diffusion will also depend with the partial pressure of oxygen, the ambient partial pressure of oxygen. But as I explained, depending on the altitude, and then we saw the picture of Mount Kilimanjaro. So the hypoxic hypoxia mainly occurs due to the decrease in the pressure of oxygen in the either ambient air or in the blood vessels. So this mostly will be due to the change of altitude. Once you go to the higher altitudes, that's when you experience the fall in pressure. And as we remember, the total pressure will also affect the partial pressure. So if you have low partial pressure of oxygen, if you see this image over here, when you go lower, you have increased partial pressure of oxygen. Taking at zero, here Bari, Italy, the partial pressure of oxygen is around 150. But if you go at altitude around 2000 meters, Mexico, the partial pressure of oxygen drops up to 109. And if you go up to Mount Kilimanjaro, it goes up to 70s. So you can see that will also affect the partial pressure of oxygen in the blood, which will also lead to hypoxia. And that's what we call hypoxic hypoxia. Next slide, please. So another type is anemic hypoxia. So this mostly, it explains by itself, anemic hypoxia. So this type of hypoxia, you have good ambient pressure of oxygen or good partial pressure of oxygen within your alveoli, and your lungs are functioning very fine, very well. But the oxygen carrying capacity of the blood is reduced. If you remember the equation which we had seen earlier, the oxygen carrying capacity will depend on the equation. There is also part of hemoglobin. So if you have little hemoglobin or lesser hemoglobin in the body, is cases of anemia, that's where you have little carrying capacity of oxygen. So your tissue will have less oxygen because of that. So most of the time is when the carrying capacity of oxygen is impaired, but also can be experienced at times when you have carbon monoxide poisoning. That's when your hemoglobin are not being able to carry the oxygen rather than they take carbon monoxide. So the amount of oxygen in the blood will be reduced only because the hemoglobin will be saturated with carbon monoxide. Next slide, please. So another type which we have is stagnant hypoxia. So what is stagnant hypoxia? This usually occurs due to reduced blood flow to the tissues. So this normally implies that you have normal partial pressure of oxygen, you have normal hemoglobin, so your lungs are functioning very well. You're getting enough oxygen from the atmosphere, but with all of this, less oxygen is being able to reach your tissues. So most of the time it's just due to perfusion disturbances. So here we have this famous perfusion triangle. So what it can impair perfusion? So most of the time we start from the pump, which is the heart, and then also the pipe, the conduits, which are the blood vessels, and then also the content within the blood. So anything which can cause like heart failure or anything which can cause pump dysfunction can also lead to stagnant hypoxia, that you are able to oxygenate your blood perfectly, but you cannot distribute it to your tissues. So this, especially patients with congestive heart failure or congenital heart defects, this is the most commonly type of hypoxia which you should expect. Another slide, please. Next slide. So another, which is the fourth one and the last one, this is histotoxic hypoxia. So this type of hypoxia usually manifests due to decrease the capability of the tissues to utilize the oxygen. So mostly the oxygen is able to reach the lungs, it's able to to diffuse to the blood, it's able to be pumped all across the tissues. But once it reaches the tissue, if you remember the second slide, that's where the ATP has to be produced, the cellular respiration, but it's unable to be utilized over there. So the oxygen utilization within the cellular or the mitochondria is impaired. Mostly it's due to poisoning, but it should be kept in mind, as most of people will not usually like to prefer to define this the standard definition of hypoxia, because you have adequate oxygen supply at tissue level. It's rather that the tissues are not able to utilize the oxygen. So normally this will experience, as I said, you will experience this when there is poisoning. And most commonly poisoning is cyanide poisoning or sulfide poisoning. But sometimes this has been linked to use of alcohol or tobacco or smoking or excessive use of narcotics. But mostly you find it in cyanide or sulfide poisoning. Next slide. So who needs oxygen? So as I said earlier, oxygen is a drug. It should not be given to everyone. This person is hypoxic, then just give oxygen. But you should understand, why are they hypoxic? From all the four definitions or all four types of hypoxia, then it will help you to know what appropriate method of oxygen should I use, or what amount and what delivery device should I use. So this is the part where my colleague will come in and continue with this webinar. Thank you all.
Yeah, thank you so much, Dr. Luisa. That was a very wonderful, wonderful presentation. I think our participants have grasped one or two things. So at this point, I'm going to introduce the next presenter, Dr. John Kweyamba, who will take us through the subsequent slides. Dr. John Kweyamba, are you there?
Hello. I'm there. Can I continue? Okay.
Yes, please. Yes, please. Thank you.
Okay. Hello, team, or hello, participants. My name is John Joseph Kweyamba, anesthesiologist practicing at Muhimbili National Hospital, Loganzila, as anesthesiologist and critical care specialist. So my part will be, will take you through who needs oxygen and oxygen delivery devices. Most of the terminologies are already explained in the first part of the presentation. So we'll be through in a few minutes. So who will benefit from oxygen therapy? From this slide, you see the table that there are types of hypoxia that when you give oxygen therapy, your patients will benefit more. For instance, hypoxia, the effect will be plus. This means that the effect of administering oxygen will be reflecting on the saturation and partial pressure of oxygen in the patient blood. But anemic hypoxia, you have to correct anemia first. A stagnant hypoxia you need to correct the low cardiac output states, and the histotoxic hypoxia, you need to correct the injury of tissues and cells that so that your oxygen can be effective when you give it. Next slide. So the indication, patients with hypoxia, that is low tension of oxygen in the blood and in the surrounding, the normoxic hypoxia in low cardiac output state, you correct the anemia, you correct the heart issues, but also you supplement with your oxygen. In situation where there are trapped gases or obstruction, and in special situation like in anesthesia during surgery, you need to supplement oxygen because the patient is in tension and stress. So you have to supplement oxygen so that you have a good physiological outcome. Next slide. So how do you recognize that your patient is in hypoxia? So in the clinical sign, your patient will present with uttered mentation. Kids most of the time represent with nasal flaring, the use of extra accessory muscles, tachypnic cyanosis, central cyanosis, but also in pulse oximeter, the saturation will be below 94%. And the blood gas analysis, the partial pressure of oxygen will be below 80 millimeter of mercury. Next slide. So in the presentations, the patient in acute hypoxia will present with restlessness, disorientation, confusion, in coordination with impaired judgment, with air hunger from that diagram you saw in the previous slide, with circulatory changes so that there is compensation. So the patient will present with tachycardia, or that can go to bradycardia if eventually. But patients with chronic hypoxia who have been having hypoxia for the long time, for instance, the patient with COPD, they present with fatigue, drowsiness, and delayed reaction to time. Next slide. So in assessment, you have to assess, you have to do your clinical examination. You will see there will be wheezing sometimes for patients presenting with asthma, so you need a bronchodilator first. Crackles, so patients with pneumonia, respiratory distress syndrome, and especially this era when we had patients with COVID, so encourage deep breath and deep coughing. And if the patient has fluid overload, you have to limit fluid that you are giving to your patients. Oxygenation level, you should review your arterial blood gases. That will be below 80 millimeter of mercury, and the pulse oximetry will show you the low amplitude and low saturations. And other investigation, you can do your full blood picture if you want to know if it's anemia, chest x-ray, CT scan to see if there is pathologies that pertain to that hypoxia. So in patients in ICU or patients in theater, so you should look on the obstruction, if there is laryngospasm or occlusion of the circuit, misplaced the endotracheal tube, or the kinking of the tube. So in breathing, you have to look if there is hypoventilation. If your ventilation does not match with the perfusion that you are giving, bronchospasm in circulation, if the patient has bradycardia or low cardiac output states, so has bled more, is in shock, hypovolemic shock, the patient has embolism. If the patient you have given medications with respiratory depression, and the patients have gone to anaphylaxis, and look on the equipment, look on the breathing circuit, the delivery of your gases. If you are giving also if you are giving nitrous oxide, there is a concept of hypoxic mixture, or you are giving the gases in the theater, there is a possibility of giving more gases than more inhalational gases than oxygen. So you have to look on your mixture, and if you should look on the trace of the monitors if there is a monitor failure. So you start with the patients and then you go to your equipments if there is a fault on the recordings on your monitors. Next slide. We need to in this session we have important aspect, the oxygen delivery devices. So we need to know the performance, the flow rate of gas out of the device, and inspiratory flow rate created by the patient. So the ID device, the gas flow should exceed the patient's peak inspiratory flow so as not to entrain air from the atmosphere. Next slide. So we have low flow system and high flow systems. So low flow systems, these contribute partially to inspired gas where the patient breathes, and high flow system deliver specific and constant fraction of inspired oxygen while when they independent on the client breathing. So when you are giving therapy, we start with the low flow system to go to the high flow system. Next. So we start with the nasal cannula. We use it most of the time in the wards, emergency department, sometimes in the high dependence unit. So there is the use, this use the dead space of the nasopharynx as a reservoir for oxygen. So the final fraction of inspired oxygen depends on the flow of oxygen from the nasal cannula and patient's minute ventilation and the peak flow. So 1 liter per minute of flow may increase your FiO2 by 3%. And the advantage of nasal cannula is patient comfort. And there are a couple of problems with nasal cannula that you need to be, it needs to be well positioned on the nares, and effectiveness of the nasal cannula depends on the pattern of breathing of the client. Next slide. So we have the face mask, we have the simple face mask and face mask with the reservoir bag. So we advance to high FiO2 when we use face mask, whereby the simple face mask at the 6 to 10 liters per minute can give you a FiO2 ranging from 0.4 to 0.6, and face mask with the reservoir bag at the flow of 10 to 15 liters per minute can give up to the fraction of inspired oxygen of more than 90%. Next slide. We have also the delivery devices that are called Venturi mask. These use the Bernoulli principle, whereby the constriction that you see on the tubing that go into the mask, they have the constriction that entrap room air together with the oxygen that is delivered. So depending on the color coding and the flow that you are giving will give certain fraction of inspired oxygen. So when you want 24%, you go to 2 liters per minute, or use 3 liters per minute if the respiratory rate is more than 30. So it goes by that. 28%, you go to 4 liters per minute, 35, 8 liters per minute, and 40%, 10 liters per minute. So it depends on the color coding. The slide does not show the the fraction of inspired oxygen because it's tiny, but you have to read that if you want to give, for instance, fraction of inspired oxygen of 60%, you use a certain Venturi with that prescription with 15 liters per minute. Next slide. So what are the issue with oxygen therapy? Dr. Alex had explained earlier. So your patient can go to the drying the mucous membrane. That's why sometimes when you have intubated your patients in the ventilator, we put the humidifier, but the patients using the low flow delivery devices, we use there is that risk of drying mucous membrane, and there is reversal of compensatory hypoxic vasoconstriction. We know it's normal in the body that when you have hypoxia, there is vasodilatation, but in the respiratory system, it goes to vasoconstriction because of the physiological changes that were there during neonatal development, fetal development that were there. But if you go along with the oxygen therapy, there can be reverse of that with reverse of compensatory hypoxic vasoconstriction, depression of ventilation in COPD, and it can go to atelectasis and absorption collapse and oxygen toxicity. And if you have compressed gases, oxygen is a good oxidant. It can cause fire in the wards and in the hospital. Next slide. So if you have patient XY in ICU, 1 hour post-laparotomy with saturation of 83% on 2 liters per minute oxygen, with nasal cannula, what is next? What will you do? So is the pulse oximeter working accurate? Do I have good signal from the oximeter? Heart rate, plus or minus, is the heart rate okay? Is there adequate perfusion at the probe? Can the probe be repositioned? Do other vital signs or clinical manifestation give evidence of hypoxemia? So you have to ask yourself questions before you act and get that reason. Next slide. So how much do you need? Ensure the oxygen delivery device is attached on oxygen, not on medical air. Follow the tubing to the source. So are the connection tight? Is the flow set high enough to give me enough FiO2 and good saturations? Next slide. Put your patients in a semi-fowler position to relieve anxiety, and reposition the patient is very important to raise the head of the bed and encourage deep breathing. Next slide. So you should reevaluate if you don't, if you have done all things right. So is breathing pattern regular and at the normal rate? Pink color in the nail, bed lips and conjunctive and the eyes. No confusion or disorientation or difficult with cognition, arterial oxygen, concentration or hemoglobin. You should look on the oxygen saturation with normal limits. Next slide. So what else can you do? You can go to high flow. In the presentation, you can see we have our CCV, compressive care ventilator, whereby it can give you the CPAP and the BiPAP with non-invasive ventilation with the CPAP mask. If you see that you have done all the necessary and the patient is not improving, you can go to the non-invasive. And if it's not improving, you can go to the invasive ventilation. Next slide. So these are sources of oxygen. Despite on the center that you are, where you are working, you should have at least a source of oxygen whereby you will help out your patients who are going through hypoxemia. And we know that it's one of the cardinal causes of cardiac arrest on patients in hospital. So we need to have a source of oxygen that is throughout. So you can use your concentrators, oxygen concentrators. There are various of them. Cylinders, different sizes, size E, size J. And in other parts, we can have a manifold system whereby it is a set of cylinders that in the manifold which are connected to the hospital through the pipeline to the wards and theaters. We can also have liquid oxygen, whereby this comes with the virtual insulator evaporator, which evaporates the liquid oxygen to the cylinders and to the pipeline in the hospital. Also, currently, many hospitals are putting on the oxygen plants that you can have your own plant that gives you enough source of oxygen. Next slide. So these are references that you can go through after this presentation. I think in conclusion, oxygen saves life. It is vital, essential drug that must always be available in all clinical areas for various clinical uses in emergency department, in theater, HDU, ICU, in general wards. Important for healthcare providers to have adequate knowledge and the principles of oxygen therapy. With various sources of medical oxygen exist of varying with various complexity, and oxygen concentrators are the most basic but essential oxygen sources that can be used to sustain patients with low oxygen needs. Okay, these are references that we recommend. You can go through them. Next, thank you. I think I will go, I can turn back the mic to the moderator, Dr. Ndab.
Yeah, thank you so much, Dr. Kweyamba and Dr. Luisa, for this very wonderful presentation and session. It's a very rich presentation, and I know that the topic about oxygen therapy is very wide. So we can only ask our participants to make reference to whatever literature and resources that they have access to, so that they can widen their knowledge. Indeed, like I mentioned, this is a very, very important topic for obvious reasons that oxygen indeed saves life. In every emergency situation, you will all agree with me that the first and the most common intervention, and which is actually simple to do, is to administer oxygen. So it is very important that we all have this basic knowledge of how oxygen should be administered, when oxygen should be administered, to which type of patient. Yeah, so the most important question that we should always look at or start by asking ourselves is starts with the patient. First, we need to recognize that the patient needs oxygen. And this is what we have gone through in the session. And usually this is not a very difficult thing to do. Once you recognize that the patient needs oxygen, the next question is, how much oxygen does this patient need? So when you answer that question, how much oxygen the patient needs in terms of flow or in terms of FiO2, then your next question is, what device do I need to deliver this amount of oxygen to this patient? And this is where Dr. Koyamba took time to take us through the different oxygen delivery devices, which can offer different percentages of FiO2 at different flow rates. So it's important that our participants take time to understand the differences between these oxygen delivery devices that we have available. And I think we've all had an opportunity when we had the COVID pandemic to actually have to acquire some more knowledge on oxygen therapy and also oxygen delivery devices, because most of the patients with COVID that had severe symptoms required oxygen. And so at one point or the other, we might have delivered oxygen, and we might have seen the variety of oxygen delivery devices that exist. And then the next question is now to ask yourself, what source of oxygen do I have? Do I have a concentrator? Do I have a cylinder? Do I have access to a manifold? Do I have pipeline? That would depend on the amount of oxygen that the patient requires. Those patients that require a very high flow, very high concentration, very high pressure oxygen might need much more complex sources of oxygen, like high cylinder pressure or oxygen, indeed oxygen plants. So thank you so much to the presenters. At this juncture, may I ask if there's anyone with a contribution or a clarification or any questions or comments or experiences they have to share with us. You can either raise your hand, and in the absence of that, you can unmute your microphone and just go ahead and speak to us. Yeah, if you have any contribution or indeed any additions, please feel free at this point to make your comments. I may also invite my colleagues, the panelists, or indeed even our presenters, if there's any additional information that we may want to share with our participants, kindly feel free to contribute. Whilst we are waiting for any hands, let me turn to the chat box. In the chat box, we have a question. So Tindi Mwebwa Josie says, what are the variable performance masks as opposed to fixed performance masks? What's the difference between a variable performance mask and a fixed performance mask? Dr. Koyamba, do you want to make a comment? Josie has asked a question, or any of our panelists.
Okay, I would like to make a comment on that. So the variable performance mask are the mask that you give a certain flow, but you are not sure on the FiO2 that you are getting. But fixed performance mask, as you saw in the presentation, like the Venturi, that in a certain flow, in the certain color coding, you give a fixed diffraction of inspired oxygen. That's what I can do. I can comment on that. Maybe
Can I add?
Yeah.
Okay, sure. Thank you so much, Dr. Koyamba. Okay, Dr. Sipet, you can add.
Yeah. Thank you for the nice question. I quite agree with what Koyamba said. So it depends on the peak inspiratory flow rate. This is what will govern how much will go in or how much will, if there be any entrapment or not. So as he said, with the Venturi and the mask with the reservoir, these are the ones which will almost give the constant FiO2. So these are sometimes they are called the fixed ones. The variable ones, these are the ones which will depend on the patient peak flow. let's talk, they're talking about the normal mask, talking about the nasal cannulas. So there will be like a variation in the FiO2. So that's what I wanted to add. So the key thing there is the peak inspiratory flow rate. That's what will determine how much FiO2 will be with the variable ones.
Yeah, thank you so much. Yeah, thank you so much, Dr. Sweetbet and Dr. Koyamba for that response. And I think it suffices. I hope that Josie has gained something from that explanation. I still can't see any hands up. I'll proceed to the next question in the chat box. So Josie goes on to ask another question. When do you humidify the gases? When do we humidify the gases? So anyone to take a go?
Okay. I will take that question. So we humidify gases when we bypass a normal physiological mechanism of humidification. For instance, the intubated patients, you bypass all the physiological aspects of humidifying gases through the nasal cavity and so forth, so that when you bypass, when you give oxygen to that patient without humidifying, it means that you are giving dry air without any humidity. So in those patients, especially ICU patients, you have to humidify so that you compensate for that physiological escape of normal humidification. That's my response on that.
Yeah, no, thank you so much, Dr. Koyamba. And I think, okay, you can add on, Dr. Luisa.
Add on.
Yeah, if I can add up, yes, as Dr. Koyamba has said, we all know that the main function of the upper airway is also for humidification and filtration of air, which goes in. But whenever you bypass that, as Dr. Koyamba has said, then also you should put a humidification device. But also when you're using a high flow of oxygen, especially for a prolonged period of time, more than 12, 24 hours, it's also recommended that you humidify, because the air which you breathe, the flow, it's relatively low. But when you give a high flow, then even the time for humidification in your upper airway, it's usually not sufficient enough for it to achieve full humidification. And we should know when you don't humidify the air and then it goes down there into the lower airway, what are the problems which might happen to your patient. So the dryness, discomfort, sputum retention. So that's also, you should know why are we humidifying. And when you find the patients who have those complications already, you can also humidify the air regardless of how much in terms of flow are you giving.
Yeah, thank you so much. Thank you so much, Dr. Luisa, for that additional comment. Indeed, humidification is very, very important. And you would see that I think most ventilators or even the external flow meters would have a provision for you to be able to humidify for obvious reasons that our presenters have given. Wonderful question. The last question, I can't see any hands raised still. I would go ahead and read the last question. The last question reads, how would you advise clinicians to simplify which oxygen delivery mechanism they are using? It seems like there is heavy reliance on nasal cannulas in low middle income countries or in low resource settings. Yeah, so it seems there's heavy dependence and reliance. The only thing people know is nasal cannulas. This is according to this question. So how would we advise clinicians or nurses or healthcare providers on which oxygen delivery mechanism to use?
So if I take that question, and I'm sure my friends and my colleagues are going to add up. So from this webinar, we saw that oxygen is a drug. So if you're using a drug, you should monitor it, and you should have proper indication to administer oxygen. So if you're giving oxygen, you should know how much you are giving. Dr. Koyamba has shown us the nasal cannula can deliver up to how much FiO2. The face mask can deliver up to how much FiO2. So how much is your patient requiring? Are you monitoring your patient? So for the moment, the best advice which I can give them is to monitor and to make sure that the patient have absolute, they're indicated for the oxygen therapy, and then they should give appropriate oxygen therapy, which is needed by that specifically patient, rather than giving nasoprongs for all patients. So should be individualized at appropriate dose or prescription, and should be monitored so that we do not give nasoprongs to all of our patients. My colleagues will add up on that.
Thank you, Alex. I think what I will say is, oxygen, like any other drug, you need a light dose for the light patient. So if you have a patient who will benefit, and remember, you have to know, even with the nasal cannula, how much FiO2 are you giving? How much FiO2 are you giving with the face mask or any other devices? So I think we should. I would agree with Alex. Let's choose the light device for the light patient. Yeah, as we say, the oxygen are the drug. It also needs the right dose, so that you can manage your patient, but also you should not end up with the oxygen toxicity and other things. So I quite agree with what Alex said.
Thank you so much. Thank you so much, Dr. Sweetbear, Dr. Alex, for those responses. I still can't see any hands up or any further comments or questions in our chat box. I would like to. Okay, there's a new comment in the chat box. This is from Jean. Jean from Liberia says, thanks for this presentation. It is an eye-opening for us who live in the poor settings. We don't usually consider right masks to the right patient, which I think I totally agree. I think most of us, the oxygen delivery device that most people are familiar with is a nasal prong, like I think the previous comments. They are the nasal prongs or nasal cannulas. But it's important to know that there's a variety actually of oxygen delivery devices that are even better than the nasal prongs, depending on your patient that you have. Yeah, so I don't see any further questions. I would like to ask Mariam to go to the recommendations slide.
Dr. Ndaba, I think we actually have one hand raised, so I will unmute before we go there.
Okay, sure, thanks. Oh, okay, Dr. Dati, kindly unmute your mic and go ahead.
Yeah, thank you very much for this lucid presentation and the comments. I definitely decided to wait to the end because what I wanted to comment on might be asked, and some of them have been addressed. I want to emphasize that documentation is very important. Document the prescription, you document what you have monitored, you have the clinical signs, and you have your values from pulse oximetry. And that will, when you do that, is when you come back. Oh, hello, can you hear me?
Yes, yes, we can hear
Yes.
you, Dr. That's very loud and clear.
Because it's raining where I am quite heavily now. That's why I'm asking. Okay. So
Hello, Dr. Dati. We seem to have lost you. Okay. I think we've lost Dr. Dati. Yeah, so okay, so I think when he will allow him to speak once he resolves the network issue. Just take me back to the recommendation slides as we wind up. Yeah, so the recommendations that we think our providers should take into account is that we should strive by all means in our facilities, regardless of the level, to invest in at least some source of oxygen, and the simplest being the oxygen concentrator, because we've already discussed that oxygen saves life, and you need oxygen to manage various clinical conditions. Other than in the emergency settings, we know that we need oxygen for surgical cases, etc., etc. So it's important that we invest in oxygen resources. And the other thing, I know Dr. Dati was coming to this, is that clinical areas should provide guidelines or oxygen flowcharts, just to serve as a reminder to providers on how they can go about recognizing a patient who needs oxygen, as well as choosing an appropriate oxygen delivery device. Thirdly, our providers should have a fair knowledge of oxygen delivery device through opportunities like this one, or just making reference to different literatures so that you are able to effectively match oxygen therapy to oxygen requirements. So the knowledge of the principles of oxygen therapy is key in order for us to be able to administer oxygen appropriately. Yeah, so I don't know if there's still any hands up or there's still any additional comments from the panelists before we conclude, and before I invite Magdalena, our global training manager, to close. Are there any additional comments?
We do have Dr. Dati back. So
Okay.
I think he can finish his comment. Yeah.
Okay, Dr. Dati, kindly unmute. Go ahead and make your comment or contribution.
Yeah, sorry, it's raining quite heavily here. So
Okay.
what I found useful, I learned from our Eco Assist International project that we were part of during the pandemic, that there's a huge gap in this oxygen therapy, because there are nurses. They constitute the people on the ward that are with the patients most of the time. So what I'm trying to say is that these devices and then the prescription and the monitoring, we should scale down that training, step down training to them. And that really helps you to administer the oxygen properly. And regarding the devices, every day, we should look at what we have in our setting, so that you know how to administer this oxygen, you know your limitations. But there's no point giving oxygen with the wrong device. Thank you very much.
Thank you so much, Dr. Dati, for that very valuable contribution. It's always a pleasure to have you part of our meetings, so that you share your valuable experience and knowledge. We really appreciate your commitment. At this point, allow me to read the last question, and then I'll invite Magdalena to close. So the last question in the chat box is from Aisha. Aisha is asking, what frequency of pulse oximetry monitoring is recommended when treating a patient? What frequency of pulse oximetry monitoring is recommended when treating a patient? Does any of our panelists want to take a go? The question is, how often do we want to do pulse oximetry or measure oxygen saturation when we are treating a patient? Anyone wants to take a go?
So I'll take a go on it. If I understood it correctly, it's more like how often are we supposed to monitor the patient who is being treated for with oxygen therapy. So I would recommend, if we are in the hospital setting with all the resources available, it should be continuous monitoring of the patients with the pulse oximeter. But knowing that resources sometimes are quite constrained, so if we have only one, I assume that there are places, or I've seen places where you have only one pulse oximeter in the whole hospital or in the health center or facility. So I would just recommend that clinical monitoring first. We have seen the signs so that you can monitor your patient when and notice them early when they start to deteriorate. So clinical monitoring can be done when you don't have adequate or good amount of pulse oximetry in your center. But if you are at a resource well-equipped center, then continuous monitoring will be advised. But other monitoring should also be not forgotten, especially when you are in a resource-constrained place. But there are patients who can be discharged even at home with oxygen. We've seen after the pandemic. So sometimes you can just do the monitoring when the patient reports the changes, especially for the cases of chronic hypoxia. As I said earlier, it can be acute or chronic. But if you're in the hospital setting, assuming that it's acute hypoxia, we recommend that it should be continuous pulse oximetry. Thank you.
Yeah, thank you so much, Dr. Luisa, for that wonderful explanation. Indeed. At this point, I think we've come to the end of the session. I would like to invite Magdalena, our global training manager, to close the session. Max.
Thank you, Dr. Papicho. Thank you, Dr. Alex. Thank you, Dr. Ndava. Thank you, Dr. Alex. Thank you, Dr. Kwayamba, for the wonderful presentation. Thank you also for our attendees. We do thank you for taking time to join us and to go through with our doctors on the oxygen therapy. Indeed, as Dr. Dati said, that during the pandemic, we noticed that there was a gap on issues on oxygen therapy, especially with the use of the masks, especially now that intubation was not being done and people had to go the NIV way. And we did try our very best as Gradient, as we had distributed many of our ventilators. It's called the CCV. It's both a transport ventilator and an ICU ventilator to many hospitals. I bet a lot of you have encountered it. We did notice that there are such gaps when it came to using the CCV, and also even things to do with how the amount of oxygen pressure. I know I'm not very good at that because I'm not in the medical unit, but I'll just say that was giving people a little bit of some challenges on how to just equate the pressure and the oxygen levels and all that. But then that is why we are doing these webinars. And also to just alert you also, you can visit our website just Google Gradient Health Systems, and you will go to our website and you will see other machines that we produce. We are soon launching the KO2, which is another machine that would be producing oxygen, and especially for hospitals in low resource areas where oxygen is a challenge. And you see now the importance of also attending the oxygen therapy, because I know many of us are going to be encountering that machine soon. And we will be meeting with you on the ground. So hold on for that, especially when you come for the All African Conference in September in Rwanda. We shall be launching it. So welcome to our bench there, where we will be. You can just come and stop and just see what we have to offer: the anesthesia machines, the ventilators, and also now the KO2. Mine is to just thank you and watch out for another webinar. Please feel free to send topics that you would like us to bring up. And yeah, thank you very much and have a lovely one, all of you.
Okay, thank you so much. Have a lovely evening, lovely morning, and lovely afternoon. Bye-bye.